Can I ask if we're going to get right to it, so if the second panel would be seated, I'd appreciate it.
You need any help?
Hey, Joe.
All right, right.
I'm sorry. Trust me, I was looking.
Who are you?
I'm gonna get one more. We're so good. Get together soon.
That would be great.
I hope so.
Switches.
So what do you think?
If you could take your seats. Are we missing Dr. Shern? Outside? I think we'll start at least with the introductions. And is that Dr. Shern? Great, thank you. Let me introduce the panel. Again, this is the panel on consumers' views. And from my left is Dr., or I shouldn't say doctor. You may in fact be a doctor, but she's certainly well known in any case. Marian Wright Edelman, who is president of the Children's Defense Fund. Thank you for being here. Next is Jenny Chin Hansen, who is president of AARP. And then we have Dr. David L. Shern, who is president and chief executive officer of Mental Health America. Dr. Eric Novak, who is an orthopedic surgeon with Patients United Now. And finally, Shona Robertson Holmes, who is a patient at the Mayo Clinic, I assume in Rochester, right?
No, Arizona.
In
Arizona.
Arizona, okay. Again, you know, we have 5-minute statements. Your full statement would be submitted for the record, and whatever else you would like to put forward, and then we'll have questions after, and we will get written questions after, you know, in the next few days to be submitted to you in writing. And I'll start with Ms. Wright Edelman. Thank you for being here. You've been here so many times.
Well, thank you so much for the opportunity to testify on behalf of the 9 million. Are we on?
Is it green light on?
No, now it's
There you go.
Thank you for the opportunity to testify on behalf of the 9 million uninsured children and the millions more underinsured children, which we have a chance to correct this year. And we've said many good things about your proposals. They're in the written testimony. I want to just limit myself to my hopes for true health reform for all children and pregnant mothers within any health insurance plan. So whatever you adopt, as a health insurance plan for all Americans, I want to just make sure that all children, all pregnant women, are treated equitably and get affordable, comprehensive coverage. And what a great opportunity this is. I'm so pleased and thank you for the CHIP bill that you enacted and the President signed, and that was a significant step, but we now have a chance to finish the job. That was not true health care reform for all children, and it is not the child health mandate that the President promised. But here we can do it now. The need for health care reform that expands coverage for all children, cure benefit inequities between CHIP and Medicaid children, and establish a national floor of eligibility of 300% to end the lottery of geography across 50 states and to simplify enrollment and retention, particularly in Medicaid and CHIP, are the key things that I hope that you will address in your final health proposal. These particularly devastating economic times when the number of poor children could rise by 1.5 million to 2 million more. The need for a guaranteed, strong health care safety net to ensure their continuous access to coverage and every opportunity for a healthy start in life is absolutely urgent. I want to just address these 4 points for a brief moment each. One is I hope you will assure that health coverage is affordable for all children and pregnant women, and with a floor of 300% of the federal poverty level, which is about $66,000 for a family of 4. Just as all children in the United States are entitled to a free public education, all children should be entitled to affordable health care. The high number of uninsured children exacts a high health, economic, and social toll on these children, the families in our nation. Uninsured children are at high risk of living sicker and dying earlier than their insured peers and are almost 10 times as likely as insured children to have an untreated medical need. These consequences of untreated medical needs can carry on into adulthood, and we must prevent them. The consequences of being uninsured fall disproportionately on children of color, who represent almost 2/3 of all uninsured children. Children of color are at higher risk than white children of having unmet health and mental health and dental health needs, and they are at greater risk of being sucked because of the absence of this preventive health and mental health coverage, of being sucked into something that the Children's Defense Fund is very concerned about, that we call the cradle-to-prison pipeline. Many children without mental health services are having to be locked up in order to get mental health care in their community at an enormous cost of $100,000 and $200,000 a year. Children should not have to go to jail in order to get mental health coverage. You can cure that this year. Yeah. The need for health care begins with maternity coverage. We have 800,000 pregnant women who are uninsured and having babies every year. They receive less prenatal care than their insured counterparts. They face greater risk for expensive and tragic outcomes, including complications, low birth weight, preventable illness, and even infant and maternal death. We have about 350,000 low birth weight babies in the most recent data. Their cost is 25 times greater than normal birth weight babies. We're the only industrialized country that does not provide prenatal care to all of its mothers. You can cure that. Hope your Health Reform Act will do that. All of our children need to be able to get what they need regardless of the state they live in. Today, each state sets its own income eligibility level for CHIP and Medicaid, which results in a profoundly inequitable patchwork of eligibility across the United States. Imagine being a low-income parent or grandparent raising several children. One is eligible for Medicaid, the other is eligible for CHIP, with different income eligibility standards and benefit packages for each program. Why should a child in North Dakota be eligible for CHIP if their parents earn more than 150% of the federal poverty level, while in 12 states in the District of Columbia, families can earn twice that amount and children are still covered? Children's ability to survive and thrive and learn must not depend on the lottery of geography of birth. A child is a child wherever they live. They should have the comprehensive benefits. We must end this inequitable system. 10 states have no children eligible for Medicaid above 133%, but offer Medicaid to children of all ages and families with income, but half of our states, offer Medicaid to children of all ages and families with incomes above 133% of the federal poverty line. Almost half cover children at 200%. 39 states offer CHIP to children to families between 185 and 400% of the federal poverty line. We urge a national eligibility floor of 300% for all children, pregnant women, wherever they live, and we should not force parents to have to choose between paying for child care, paying for health care, paying their rent, and so this is our chance to sort of give them the kind of national health safety net that I as a grandma have. I think I'm important, but I think my grandchildren are even more important, and we should treat them fairly. Secondly, we hope that all children will have the same comprehensive benefit packages, which include health and mental health coverage. We like the EPSDT program. It was designed and was appropriate for children. Children are not little adults. It has health and mental health coverage. We believe, and if you believe, that every child's life life is of equal value and that children don't come in pieces and they should get what they have to have their conditions diagnosed and treated early and prevent later costs, I hope you will make sure that every CHIP child and every child in the exchange will get the same benefits that the Medicaid children get.
I hate to slow you down, but you're a minute over.
I'm a minute over already. Good gracious. Then thirdly, two last quick things, and I will just end, Mr. Chair. All of our eligible children should have simplified ways of getting and keeping enrolled. The bureaucratic barriers that keep 6 of the 9 million uninsured children now unenrolled need to be addressed. The package, as I see it, does not do that. We think that when we lay out in our testimony, our written testimony, and we lay out in specific legislative language in the Old Healthy Children's Act, the steps that you can take to make Medicaid work. I'm glad you've moved to 133% of the federal poverty level for adults, but children are already eligible for 133%, but they're not getting it because of the bureaucratic barriers, which you must address through the simplification measures we lay out. And last, I just want to say, I know people are saying cost, and we can't afford it. Well, you know, we can afford whatever we want to afford. We do not have a money problem in a nation with a $14 trillion GDP. You found the money to bail out the banks. You found the money to bail out the insurance companies. You found the money to do the alternative minimum tax. We can find the money if we believe in it to make sure that we give our children the chance to survive and to thrive. And they are cost effectiveness. And while CBO may not score prevention, we know that $1 invested in immunization saves 16 on the other end. We know that if you give a child an asthma visit in a primary health care setting is about $100 in Harris County, Texas. It's going to cost you $7,300. They go to the emergency room and have to be hospitalized. If we want to contain costs, children is the way to do it. All of them should be covered. All should get the same benefits. It should be simple and easy, and you have a great opportunity to do it right this year. Thank you.
Thank you. Ms. Jenny Chin Hansen.
Thank you. Chairman Pallone, Ranking Member Deal, and distinguished other subcommittee members. I'm Jenny Chin Hansen, President of AARP. Thank you very much for inviting me to be here today and for your leadership on leading comprehensive health care reform. Enacting legislation to give all Americans quality, affordable health coverage options is AARP's top priority this year. The draft tri-committee legislation marks substantial progress toward this goal. Today, I'm really proud to represent nearly 40 million members of AARP, half over the age of 65 and half below 65. Both age groups face serious problems in today's healthcare system, especially the 7 million people aged 50 to 64 who are uninsured. The draft includes critical reform priorities for AARP members for all ages. For our younger members, it would curtail discriminatory insurance market practices that use age and health status to block access to affordable coverage. Reform must include strict limits of no more than 2 to 1 on how much more insurers can charge to people who are in this age bracket of 50 to 64. Reform must also provide sliding scale subsidies for those who need help to make coverage affordable, as well as provide some strict limits on cost sharing. The draft legislation achieves our goals on these vital points in healthcare reform. For our older members, the draft closes Medicare's prescription drug donut hole so that they will be able to afford the medications that they need. This gap in coverage has been a major reason why 1 in 5 people who get drug coverage through Medicare delayed or didn't even fill the prescription because of that cost. Under current law, the hole keeps getting larger every year. The draft begins to close the donut hole and includes other steps to lower drug costs. And for people with limited incomes, the draft closes the gap right away by strengthening the Part D low-income subsidy and eliminating its asset test that penalizes people who really did the right thing in saving for a small nest egg in retirement. The draft also fixes Medicare's broken system for paying doctors and puts Medicare on a path to fiscal stability by revising payment systems to reward quality instead of quantity of care. It includes incentives to reduce costly and preventable rehospitalizations. It strengthens our healthcare workforce that we know is actually, at this point, short already, let alone what will happen in the future. and it takes important steps to address racial and ethnic disparities in care. Many challenges remain on the road to really full comprehensive health reform, but AARP and many other stakeholders share a broad and growing consensus that any differences that we may have cannot stop us from finding common ground and enacting comprehensive health care reform this year. We know, and it's been said time and time again, the status quo is just unsustainable, and we cannot afford to fail. Thank you all for your leadership, and we continue to look forward to work with all of you in Congress to enact this comprehensive reform this year. Thank you.
Thank you. Dr. Shern?
Mr. Chairman, members of the committee, Mental Health America is honored to participate in today's hearings on ways to reform our health care system. I want to start by expressing our appreciation for the many important proposals included in the Tri-Committee bill released last week that recognize how integral mental health is to overall health. You know, this is our centennial year. Our organization is 100 years old this year, and for the last 100 years we've advocated for people with mental health, and from the beginnings of our organization we had kind of a dual vision. On the one hand, we were concerned with people who had severe and disabling illnesses who would have traditionally been treated in state hospitals, but on the other hand, from our very beginning we have had a commitment to a public health perspective and to prevention as the only real way to drive down the prevalence of illness. So we're very heartened by this bill because we see it as including many of the issues that need to be addressed in order to become the healthiest nation. We think that it addresses historical patterns of discrimination by including mental health subsidies, including parity for mental health and substance use services, and importantly, it addresses the prevention and management of chronic diseases as the real strategy to control costs and improve overall health care status. I think these are very important. You know, mental health and substance use conditions are really paradigm cases for what goes wrong when we discriminate against a class of illnesses and fail to prevent and appropriately treat them. And this resonates very much to what Ms. Wright-Edelman was talking about in terms of not addressing issues of mental health services in children. Increasingly, our science is telling us that mental health and substance use conditions, we used to think they were diseases of early adulthood. We now know that they're diseases of adolescence. They're developmental disorders that occur early in life. For all people who are going to develop a mental health diagnosis during the course of their life, 50% of those people will have that diagnosis by the time they're 14 years old. However, they will not receive services until, on average, they're 24 years old. So during that 10-year period, substantial disability begins to develop. Academic achievement starts to drop off. These are very strong predictors of academic achievement. Ultimately, occupational achievement is compromised. We need to do a much better job at early identification and addressing issues of mental health and substance use disorders if we're going to develop the healthiest nation. The reason that WHO estimates that mental health and substance use conditions are in fact the most burdensome of all health conditions, causing twice as much burden of disease as cardiac illnesses, is in part because they are diseases of early adolescence that we do not effectively address. So clearly, this bill, from our perspective, includes all the key components that are necessary to start to address this problem, at least structurally. First of all, it clearly addresses the importance of preventative services. You know, we're, I think, in some contradiction to some of the things that were said earlier, we have a brand new report from the Institute of Medicine. It was released in March. That's a comprehensive summary of what we know about the effectiveness of preventative services for emotional and behavioral disorders in children and young adults. And we know a lot. Our science base is strong. We know that community-based interventions work, and we applaud the committee for emphasizing the importance of community-based interventions. We know that early identification, when coupled with treatment, works, as the Preventative Services Task Force has indicated, and we applaud the committee for including those services as well. It's also clear, if you look at what it requires, what's required to manage chronic disease, it's very clear that in order to do that, you need to address the entire person, not the person in segments or subspecialties. The notion of the medical home that's included in the bill, I think, is extraordinarily important, and the inclusion of behavioral health services in that medical home is absolutely critical. Not only are mental health and substance use conditions the most chronic illnesses, they're the most common co-occurring illnesses with other chronic disorders, and when they co-occur, they drive costs way up, they drive outcomes way down. So the medical home and comprehensive integrated care is clearly an important part of what we need to accomplish here. You know, we have a tragedy in this country in that people with chronic mental illnesses who are served in our public system die 25 years early. 25 years early. They're dying on average in their 50s, and they're dying from a broad range of the same disorders that will kill all of us in our 70s or 80s or 90s. So it's a critical imperative that we address comprehensively need of that population as well as persons with other chronic conditions who are likely to have mental health and substance use conditions. Finally, I'd just like to say that closing the donut hole is very important for people who rely on psychiatric medications, which can be very expensive. The committee's attention to workforce provisions is critically important. As several people have noted, we have a very predictable workforce crisis coming up on us quickly. And then finally, a word about comparative effectiveness research. You know, I left academia 3 years ago at the University of South Florida, where I used to work for Ms. Castor's mother, to join an advocacy organization because of my frustration with our inability to get our incredible science base to people who need those services. Comparative effectiveness research provides a framework for us to better codify and understand what works and to translate it into information that can be supportive of individuals and their clinicians, their caregivers, in making better decisions. So I applaud the committee for all the components of the bill, which seem to nicely round out both improving the quality of care, emphasizing preventative services, and bringing better science to bear in terms of our decision-making processes. Thank you, Mr. Chairman.
Thank you, Dr. Shern. Dr. Novak?
Hi, good afternoon. I want to thank Chairman Pallone and the rest of the committee for having me here today. My name is Eric Novak, and I'm a medical doctor who's actually spent the last 23 years training and working in healthcare. Make no mistake, the variability for everyone in this room and your families to seek out the kind of health care you believe is best is under direct assault. And the risk you will lose control over your health and health care has never been greater. Unbelievably, nowhere in the U.S. Constitution or in the Constitution of any of the 50 states do any of us have any right to be in control of our own health. In November 2008, Arizona's Proposition 101 sought to place two basic rights into the state constitution. First, to preserve the right of Arizonans to always be able to spend their own money for lawful health care services. And second, to prevent the government from forcing us to join a government-sanctioned health care system. Because once we are forced into a plan, our health care options will be restricted by the rules of the plan, whether it be public or private. It was a true grassroots campaign, and an idea went from concept to well over 1 million votes in less than 18 months, and failed by less than 0.5%. Fortunately, the Arizona legislature has courageously recognized the critical issues raised by the initiatives, and just yesterday referred the Arizona Healthcare Freedom Act to the ballot in 2010. Unfortunately, the reforms that have recently passed Congress and the bulk of those that are being considered do not appear to have much respect for the basic freedoms that the Arizona initiatives seek to protect. The stimulus bill was used as a tool to vastly expand the federal health care bureaucracy. By the end of 2014, every American will be forced to have an accessible electronic health record that can be viewed by government officials without consent, permission, or notification. The stimulus bill created the Federal Coordinating Council for Comparative Effectiveness Research, whose ultimate function will be to become a federal health care rationing board for all Americans, starting with seniors. As Health and Human Services Secretary Kathleen Sebelius said during her confirmation testimony, quote, Congress did not impose any limits on it, referring to the council. And now MedPAC may be empowered to make the full slate of recommendations for every condition and treatment. Congress will only be able to make an up or down vote on the entire package. The President recently spoke to the American Medical Association, touting the importance of using evidence-based medicine to figure out what works and what does not. When it comes to the best treatments for our ailing health care system, we have some compelling evidence. Leaders in Congress regularly cite Massachusetts as the model for reform. But what really is going on in Massachusetts, and we want to repeat it on a grand scale? Costs are even more out of control than in the country as a whole. Use of the emergency room for care has not diminished despite the higher percentage of people with insurance. And there is exactly zero evidence. There is exactly zero evidence that forcing people to have insurance has made any difference on slowing health care spending. Medicare has tried several disease management and prevention projects. The idea is that spending money up front to prevent Medicare patients from needing expensive hospitalizations and disease complications will save money in the long run. Unfortunately, the results did not bear that out. Among the conclusions in the June 2007 report to Congress on the trials, quote, fees paid to date far exceed any savings produced. In other words, the cost of administering the plan made the prevention plan more expensive. Real research also suggests that obesity and smoking prevention, while admirable, do nothing to reduce health care spending. Supporters of the President have also reviewed the literature on the impact of electronic health records on spending and concluded, quote, we need the President to apply real scientific rigor to fix our health care system, rather than rely on elegant exercises in wishful thinking. And research has been done demonstrating geographical variations in health care spending, but there is no evidence that having Washington forcibly take money being spent in Massachusetts, New York, or California and sending it to lower spending states will improve anyone's health. We cannot afford to make mistakes that will mean our grandchildren will, in the words of the President, suffer from, quote, spiraling costs that we did not stem or sickness that we did not cure. Congress should fix Medicare first before radically changing the health care of every American. Congress should demonstrate that the government can prevent the disturbing failures, even more exposed this week, of the VA system before radically changing the health care for all Americans. And Congress should work very hard to increase the options and availability for the 3% of Americans who are truly, quote, chronically uninsurable before radically changing the health care for the other 97%. Health care reforms are critically needed. Our path is unsustainable. But jamming through a piece of legislation that few will have read and the American public will not have had time to fully review makes no sense. The cynics who shout that we cannot have health care reform without sacrificing our personal freedoms are false prophets offering a false choice. I urge the members of this committee to consider health care legislation that protects individual liberty, preserves privacy, limits government power, and has reforms that have actually been shown to work. In other words, reforms that protect patients first. Thank you very much for the opportunity to present my views today.
Thank you, Dr. Novak. Ms. Robertson-Holmes, thank you for being here.
Thank you. Thank you, Chairman and members of the committee. 4 years ago, sitting in my doctor's office, never did I believe that I would be here in Washington talking about this situation. But I'm here because I was fortunate enough to be able to, in amongst my nightmare, come to this country and get treatment. I actually am the face of public insurance. I'm from Canada, and we do have public insurance, mandatory monopoly on our insurance. And I'm here to say, when it doesn't work, it doesn't work. Unfortunately, in Canada, we have 33 million people, which is approximately the size of the state of California, and we currently have 5 million people without family doctors. What started many years ago as a seemingly compassionate move in our government to treat all equally and fairly by providing the same medical coverage has in fact turned into a nightmare of everyone suffering equally. Now we have limited resources and funds that offer timely treatment to our citizens. A system like this starts to crack under pressure, and special treatment is ultimately given to those who have contacts and resources to jump the line for treatment, and for someone like myself, the average Canadian citizen, forced to go to another country for care. I will never get the time, money, or life back that I've dedicated to the fight to basic treatment that I was promised by my government, but not only promised, it was ordered. I will never forget the experience of the treatment in a facility suffering so bad from government funding and shortages of staff and resources. I know that the American healthcare system is not perfect, but I do credit the system for saving my life. It is because of the choices available here in this country that I was able to receive immediate care. We as Canadians have one insurance company, the government. We have no options. We can't choose another country. We can't supplement with after-tax dollars to purchase extra care. We can purchase health insurance for our pets, but not our children. I have very few rights as a patient. Patients there have to fight for every basic service and care, much less any kind of specialized care. Another thing that I'd really like to point out is that our health care is not free. In fact, I would argue that the cost is much greater than the tax we pay, each and every citizen, towards this care. The costs are loss of quality of life while living with pain, discomfort, or just the fear of unknown, and also for waiting long-term for diagnostic testing. The cost of employers and self-employed people waiting for employees to be treated and be well enough to return to work. Medications are also something that Canadians are struggling, like Americans, to pay for. We are not covered for our medications under our health care plans. We pay the cost of local ERs closing, losing a wealth of talented doctors that leave the country because they just don't have the resources to do their job properly at home. We have rationed services and treatments and a fear of living without a safety net. The one thing that I wanted to sort of point out when I was making my testimony today was, if I have gotten any criticism from anybody that I've done for what I've done, is that I must have had the resources in order to be here today. I'm here to say that I didn't. I am so average, and in order to get what I had to do, my husband took a second job. He put a second mortgage on our house. We owe every single person we know money. And I will never forget all of that that's happened. But I also want to wake up grateful for what happened to me in America. And I want to have those same options in Canada. And I just felt from the very beginning of my experience that it was my job to point out to both Canadians and Americans what we can do together and what we need to learn from each other's situation. Thank you.
Thank you.